They're in different slides because this particular slide is together with the coronaries. Someone's doing protection for the coronaries next Thursday. So we will stop, pause for a little while, and then we will shift to another one. Okay? So pericardium. I think everybody knows what a pericardium is. Actually, if you have the pleura for the lungs, then you also have the covering for the heart. So what makes up the pericardium? So remember again, when we talk about cardiovascular system, we'll be focusing this time not on the lateral compartments of the thoracic cavity, but this time focusing more on the central compartment. If you notice, the central compartment is further divided by the mediastinal pleura away from the lungs. Then you have the diaphragm below, and the take-off of the great vessels along this particular area of the superior mediastinum. Take off of the great vessels. So when I say great vessels, take off, either it could be efferent, or meaning away from the heart, or afferent, which is towards the heart. So we're talking about the vena cava. These are the great vessels, okay? But that will be included in the blood supply. Okay, so the definition, the objectives now is we want to find out what comprise the pericardium. It's not a simple layer as we are made to believe. It is comprised of a lot of layers and its attachments, especially to the mediastinum, which practically protects the heart and holds the heart in place when it pumps every second, 24/7. It does not rest. Okay? So, the functions of the pericardium, actually, again, as I mentioned, is for protection and also acts as a part where it is, you will be surprised that it is also connected with the respiratory muscles. So whenever time we breathe, it actually moves. Okay, so it does not have to coincide with breathing because you can stop your breathing. But actually, when the muscular part of the respiratory system moves, we can now see later on that the pericardium actually is attached to that particular structure. So when it moves, it also helps in overfilling, protects the heart from overfilling or even contraction. Okay? So, primarily, the pericardium is comprised of a fibroserous membrane, which is further subdivided into the fibrous and the serous part. These are the functions, primarily. Again, take off lungs and great vessels. Not all of the great vessels. It's just a take off. So we go to the fibrous. It's the most external. It's the one that you see actually in your pelagos. It's the whitish thing, thicker. You know, when you hear the word fibrous, it's supposed to be thick. Very, 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 very clear in your specimens. And it is actually attached and continuous with the diaphragm, especially the central tendon part of the diaphragm. Now take note that when you say continuous with the diaphragm or even central tendon, you cannot actually easily separate it. It is attached. But you can see a demarcation, but it's not as easy as when you remove it. Because once you remove that particular connection of the fibrous to the central tendon, you will include also, rip also open the other big vessels and other structures that pass through it. Now for the serous layer, you have the parietal and the visceral. Just like the lungs, when you hear the word visceral, what does it mean? It is firmly adherent to the organ. Okay? So definitely, and as we go along, you're going to hear a lot of words, serous, parietal, visceral. So when you hear the word visceral peritoneum, as we go to the GIT, visceral layer of the pericardium, it is actually attached to the heart. But this one is different. It's not actually firmly adherent to the heart compared to the lungs. When you hear the word visceral pleura, it is attached to the lung. If you notice your specimens, you cannot even peel it off. If you peel it off, you're going to include the parenchyma of the lung. Okay? This one is different. Take note. No layer is attached to the heart because it's supposed to be free moving. This one is attached to the inner layer of the heart. So in other words, the visceral layer of the serous pericardium is also known as the first layer of the heart, which is the epicardium. Okay? So when you hear the word epicardium, it's the outermost layer of the heart, which is actually part of the heart. So it's not firmly adherent compared to the lungs. Now we can just compare it with the lungs in the meantime because we have already finished with the respiratory system. Now when you hear the word parietal layer, this is the one that makes up the majority of the covering of the heart, outermost. In other words, if you get to see a fibrous pericardium in your specimen, if you look at the inner part of the fibrous pericardium, that is the serous layer of the parietal pericardium. The innermost layer, the outer part is the fibrous. If you turn it around, the shiny part, that is the parietal layer of the serous pericardium. Okay? And at the same time, this particular layer is the one that is actually connecting and forming a protection to the takeoff of the great vessels. Now, mainly those are your great vessels. So we will not go back. So when you hear the word great vessels as we go along in the cardiovascular system, we are practically referring to these guys. Okay? Great vessels na sila. Of course, we are talking about them in the thoracic area. We also include, when you hear the word great vessels, as we go down in anatomy, then we also include the abdominal aorta, the common iliacs, which is towards the extremities. These are also considered as great vessels. These are big vessels. Okay? But for the sake sa cardiovascular system, only have to consider as great vessels. Okay? So we will not go back to the cardiac cycle, but nevertheless we will still review them before we understand. Okay. Is it mine? here. Okay, so going back to this focusing on the serous pericardium, it is mainly made up of the most simple cells that you can actually see, which is made up of your mesothelium, and this is actually its functions. Okay, so internal surface of the fibrous and the external surface of the heart. That's what we mentioned. Some of them will be named as your epicardium. Now, if you look at the blue lines here, those are the demarcation of the. First, we go to the fibrous, as indicated here. Take note that it is actually connected to the central tendon of the diaphragm. And the purpose here is actually simple. So when the diaphragm moves during respiration, especially during inspiration, it also pushes the heart, right? Because of its firm attachment. Now take note that it does not actually play a very big part in the contraction. It has nothing to do with contraction. But because of its protection of the heart as far as the fibrous, it prevents overfilling of the heart. So when you go to the stage of diastole, if you don't control it without these layers and with your resting phase, which is the diastole, you're going to fill up the chambers of the heart with blood. Okay, so you're going to contain it and limit it at a certain pressure, then that's the time it is going to be ejected, either towards the body or towards the other systems, or from the atrium going to the ventricles. But we will discuss that one further on the second topic. Then, of course, you have the serous layer. Take note again, the parietal serous is covering also the great vessels. This one, okay? Then actually it has nothing to do with the connection to the heart. It's only the fibrous. Of course, the visceral there is not shown. It is actually the innermost layer of the parietal serous layer, as you know these two layers. Now take note that in between the fibrous and the serous, just like again the pleura, you have a cavity. The cavity here is so small, it only has about 5 ml of serous fluid. Again, the purpose of the fluid is friction, not to firmly attach that particular heart, but again, it can be an area for inflammation or infection in that particular space. Now take note that if you have an excess fluid in that particular space, we call it as pericardial effusion. If it's traumatic, meaning if there's blood inside, or any penetrating injuries to either of the chambers of the heart, it puts blood inside that cavity and it presents what we call a pericardial tamponade. Okay, so it restricts the pumping of the heart. And you only have a few minutes to relieve the heart with that particular fluid. Of course, there's a procedure, what we call as your pericardiocentesis, which actually you use a spinal needle used by the anesthesiologist. You puncture that pericardial space, remove the excess water. It is actually also life-saving. Question there is, anatomical wise, you need to know the surface marking because you cannot just put any needle there inside your heart. You need to know a specific area. Again, we will touch that one on the later, but I'm just focusing on that particular space. Okay? You can also have conditions what we call as pericarditis, infection, tuberculosis is still quite common, but we don't see them often nowadays. Okay, so that particular fluid can either be bacterial, not much viral, and you also have tamponade from trauma and also pericardial effusion still from other inflammatory conditions like tuberculosis. And we can still see this one, although we are not from IM, we should can see the long-term message. So this is how you differentiate your pericardium. Again, if you correlate it with your specimens in your cadavers this time, you can actually see your pericardium. Now, of course, we have separate heart specimens, just like the lungs last time. Not a separate heart, so you don't need to worry about looking at it. But for the pericardium, you need to go back to your cadavers to take a look at it because the specimens that go downstairs is devoid already of the pericardium. Okay? So pan-outin mo sa central compartment, you can see the remaining spaces there. Actually, some of them are still connected to the great vessels. I mean the pericardium. Okay, so you can see the space there. So these are the functions and the importance of the fibrous pericardium as a whole. Okay, take note. Some of them are even continuous with the superficial or outermost layer of the great vessels, which is known as your punica adventitia. Okay. So, even including some of the portions of the deep cervical neck, which is the pretracheal layer. So actually, it has connections with the neck. It has also connections with the takeoff of the great vessels. So what does this imply? Pretracheal layer. When you say pretracheal, that's prior or before the trachea. So if you look at it, there is a connection between the cervical fascia on the neck to the pericardium. What is the danger there? For any infections in the neck, it can have a possibility of spreading towards the heart layer, not specifically the heart, but the layer of the heart. Okay, now if you have a fibrous pericardium that is thickened, there are only two types of conditions. When it thickens, the fluid is absorbed. So there is no more fluid, the heart will not pump as efficiently as what you want because di naman bumubuo din ang pericardium. So okay, so that's the reason why you might have condition wherein the patient have a penetrating trauma, got infected, and all of a sudden the patient developed pericarditis. So you will not be surprised anymore because of that layer, which is actually continuous with the fibrous. Okay? Other one is attached at the front with the posterior surface of the sternum. So meaning, the fibrous pericardium at the back of the body of the sternum, there is a connection. It holds it in place. And this is what we call the sternopericardial ligament. Okay? So meaning it is attached. It's not just the fibrous pericardium itself. It has to have ligaments for its attachments to hold it in place. Support. At the back, it's really not that important. It's made up of areolar tissue and some of the organs which we know as the posteriorly located organs. Now some of them will be your lymph nodes, your portion of the esophagus, portions of your great vessels, especially the elbows. And at below, or inferiorly, we already understand that it is connected with the central tendon of the diaphragm. But it is not just enough that it is connected to the central tendon of the diaphragm because it has another very, very important ligament holding it in place. But before we go into that, we have to review again the layers of the heart. Okay? The layers of the heart, take note, we have to look at the layers of the heart in correlation with the pericardium. So we review na lang nato, inner pericardial layer is also known as the epicardium or the serous layer of the parietal layer of the serous pericardium. Okay? Then you have the myo and then your endo. But again, very easy to understand. So if you look at it, its correlation with the cavity, with the layers of the heart, and the layers of the pericardium. Okay, so going back to it, you can see the space there between the parietal serous pericardium and the visceral serous pericardium. This one is the ligament I was referring to a little while ago. This is quite thick. You can actually see this not with the heart, but with the fibrous pericardium connecting to the diaphragm. So besides being firmly attached to the central tendon of the diaphragm, it is still again supported by a very strong ligament which is known as your pericardiophrenic ligament. Okay? Take note, cell number 2, it cannot be separated. So whether you like it or not, when you remove the diaphragm, I don't know what will go into your mind whether you will remove the diaphragm. if you have the feel to remove the diaphragm, you will include a portion of the fibrous pericardium when you remove it, okay? Or even vice versa. You cannot really separate it. Then again, the reason for this particular ligament, it again helps the heart from sudden overfilling during the diastolic phase. Okay. Again, the space between the parietal and visceral layers, this particular example will tell you that if you try to put a fist between these two layers, it follows your fist, the shape of your fist. And the shape of that particular fist will determine also the shape of the pericardial space in between. That is how ballotable it is, and that is how it is firmly follows the shape. So whenever the heart pumps, either congested heart failure, whatever, it follows the shape and the size of a particular chamber. That's my point. So you try to imagine if the heart itself is your fist, and the layers will just follow within how big. For example, if the left ventricle is the one that is enlarged or hypertrophic for any other cardiomyopathic conditions, who follow as a shape sa imong serous pericardium and your fibers. Okay? It does not stay in one place unlike the pleura. The pleura will not follow. If you have COPD, my point na, if one has a COPD, lung tako over distended ang lungs, the pleura will stay put. And that is the reason why lungs during expansion for this particular patients with this particular case tends to have obstructive type of lung problem. Unlike cardiomyopathy, and you will be surprised that you have to take now. There are cases wherein some of us, especially with a history of rheumatic heart, when you were a child and you were not treated, and if you take an X-ray, you will see that you have an enlarged heart, but you don't have any symptoms. Okay. You may have an enlarged heart, which is actually quite common in elderly, but your patient or your known patient with an enlarged heart does not have any symptoms. Because again, there is no such thing as restrictive heart because of the distension, because it follows the contour of the heart, ang imong serous pericardium, unlike sa pleura. Okay, so there's a big difference there, or even unlike the peritoneum with the abdominal cavity. It follows the shape. That's why it rarely goes into symptoms, because it does not restrict. The only time it gets restricted is if the pericardium itself gets infected or thickened. There's another story, okay? So if it gets infected, then that's the time the lungs is restricted. I mean, the heart is restricted. For the pleura, we rarely see pleuritis. But it's more common in pericarditis. Okay? So if you're going to correlate it clinically, that's the reason why if you have cardiomyopathy or why you have left ventricular enlargement, but there's no symptoms sa pasyente. Because it does not restrict man. Because follow ang shape ang pericardium. Okay? Okay, let's start first with the epicardium, because we already know that it is known also as the visceral layer of the serous pericardium. It's another name. It is also continuous, again, based on this illustration, actually it follows the shape, turn around naman siya. So it is actually continuous also with the parietal layer of the serous pericardium. Take note again, as a review, these are the following great vessels that goes away from the heart. These are the following vessels that enters the heart. We're not very specific yet whether it's right or left or right or left. Okay, so in general. Okay, so again, layers following the layers of your pericardium. Okay, so you have the big here, which is the parietal layer, you have the cavity here, then you have the visceral layer, which is also known as the epicardium. Okay, this is the most, the question now is, I'm going to identify these two layers. Now, if you have an intact pericardial layer, especially the fibrous and the parietal layer of the serous, there are two parts here which you can actually identify. But you can only identify this if you have an intact heart inside the pericardium and the great vessels. So if you have a separate heart, forget about looking for these guys. Okay? So for theoretical purposes, you have two cavities. Imagine na lang that intact pericardium. You remove the heart, you remove the great vessels, leaving behind the takeoff. Okay? So you're going to see there mga circles. Take away the heart, so you have an intact pericardium there. Now, this, first of all, we need to talk about what we call as the transverse pericardial sinus. This is the smaller area, and this is its definition. Okay? For theoretical purposes. Muna yung definition. Okay? Then, actually, it's found between the two take-off and entry part of the great vessels. Then, it is located behind the intrapericardial parts of the trunk, sending air down to the receipts per from the heart. Theoretical purpose lang yan. Okay? Now, if you look at it, this is what I'm describing to you. You have to have an intact pericardium there in order to appreciate your transverse pericardial sinus. Take away the heart, remove the majority of your great vessels. That area here is the transverse pericardial sinus. Okay? This one. You follow the red one. That is your transverse pericardial sinus. You have also a bigger sinus here, which is known as the oblique pericardial sinus. Not much structures that you can see. It has a bigger space because most of the space is occupied by the heart itself. Not much of the great vessels, unlike the transverse pericardial sinus. This one is usually seen by the presence of the takeoff or the entry point of the pulmonary veins. So you can see the pulmonary veins there. Okay? Once it enters the left atrium, then you can see what? What's up name? No legal side. What's this? Inferior atrium. Okay, so if I was going to ask you in a question, what are the following vessels, great vessels that you can see in the oblique pericardial sinus? If you notice, I don't give exceptions. I don't give more type on my questions. I don't give more snipes because it is supposed to be contemporary. Okay, there is also this thing as more snipes in the meaning instead, which of the following is not living in a shamayo. You know this, but there are still some word questions that come up like that. But that is not really part of the total recall, just like in terms of knowing answer. You might know the answer, but not the direct answer because you are now ruling out. So there's a difference between knowing the right answer and ruling out answers or ruling out wrong answers. Okay? So anyway, those are, if you notice, this is smaller space, the transverse pericardial sinus is with more bigger vessels. Smaller space, bigger vessels, unlike the oblique pericardial sinus. Just memorize the four pulmonary veins, two superior, two inferior, and your inferior. Okay. This is the definition. Everything is in your book. Okay, so another picture showing the oblique pericardial sinus. You rarely can see now the transverse pericardial sinus. What is the clinical significance for this? Or is it just adding for you guys to memorize? What is the clinical significance? If any one of you, 20 years from now, will become a cardiac surgeon or heart surgeon, that is the area where they enter and control the vessels. So meaning, the surgeon will enter his fingers or her fingers, I don't want to be a gender one, I'm not saying babae or surgeon, enter the fingers behind those sinuses and clamp that area there. You don't attack it directly. You attack it from behind. And that space is devoid of other structures besides the sinus. So that is where they enter, they identify the aorta, they identify the pulmonary trunk, then they control it by loops. They place loops there, vascular loops, diet, control it before they even remove the heart. So I'm talking about what? Heart transplantation. That's why I told you 20 years from now. Okay? Gabi mo na siya. Training. What's the longest informal training? If you notice, most of the heart surgeons in the States, Texas, actually, Houston is usually not the one with, okay? You don't see young. The young ones are under fellowship training, not the main surgeon. Okay? So in other words, that is where they enter sort of finger behind to control those vessels, especially this one. Now, what I'm referring to is heart transplant, which we don't do it here in the Philippines, we do it in other countries. Okay? So meaning you have to control all these vessels, all before you remove the heart. Okay, then put it back. Now, the danger there is not so much as the critical part in heart transplant is what? It's not but remove. Right? You can just clamp there, cut all those great vessels, remove the heart. It's but anastomose. That's why you need a heart lung machine. Diba? You need that machine to keep you alive for that critical part. So when you put a heart back, the most critical is anastomosis, vascular anastomosis between all of this. So muna yung isumpay-balik. Okay? So when you remove a heart from a donor, you have to make sure, just like the kidney for a transplant, you need to have a long vascular. Okay rin siya. But the donor should have long, meaning the aorta should be longer. The vena cava should be longer, so that when you anastomose, you don't have tension. You don't have tension, okay? So just imagine, forget about the nerves, forget about the one, the purpose is not the conduction. They can always put pacemakers that are artificial rather than the inherent. So, that's the clinical significance of this cyanosis. So there's not just a decoration there for you guys to memorize. Okay? Okay. You will be surprised that even though for a layer, it still has its blood supply. Maski pa layer lang siya, it has to have its blood supply. Now, take note of the 4 blood supplies of the pericardium. Number 1 is the most important, which is the pericardiophrenik. So you have a pericardiophrenik ligament, you also have a pericardiophrenik artery. But what I'm more interested is, where does it come from? Meaning, it comes from the internal thoracic artery, which is the first branch of your scleria. So important tayo, right? And it follows the route or course. When it runs through the course, it follows the course of the phrenic nerve. You already know the phrenic nerve, okay? So they know that the phrenic nerve also passes along the heart before it goes and then innervates the diaphragm. Then you have the musculophrenic. You heard of the musculophrenic before, right? 2 lectures ago. Musculophrenic is the continuation, again, coming from the internal thoracic artery, which provides blood supply to the 7th to the 9th intercostal muscle. Okay, so it also donates or it also contributes to the blood supply of the pericardium. Then you have a lot of branches there, blood supply. So take note, even though if it's just a layer, it is still very rich in blood supply. Okay. Bronchial, esophageal, even the superior phrenic arteries, all coming directly from the descending thoracic aorta. Then lastly, it also receives a blood supply coming directly from the coronary arteries. But the coronary arteries, as far as number 4, it only provides blood supply to the epicardium, which is also known as the visceral layer of the serous pericardium. Meaning, epi naman ka, so it only part na siya sa heart. So that's where coronary is. Kamari siya contribution that it only provides blood supply to the epicardium, not the rest of the pericardium, fibrous parietal layer. Okay? which are all coming from 1 to 3. Okay, and of course, example of the phrenico cardio or phrenico-cardio artery, cardiac artery, which is following the course of the phrenic nerve, okay, before it provides blood supply all over. You might not see them, do not look for them in the specimens. Actually, they're very small. Even the number 1, the main blood supply, you cannot see them. But you can see the phrenic nerve. So if you can identify the phrenic nerve, most likely it is there beside it. But with the condition of the numbers, most likely I would think you can do it very well. Okay, for the venous drainage, same namesake, pericardiophrenik vein. It directly goes or drains to the brachiocephalic vein, either right or left, and the or internal thoracic vein. Okay, so the same like a pericardiophrenik vein. And also they receive drainage points to the azygos, meaning more on the right side. Any accessory on the left, azygos more on the right. Okay, so most of them drain to the right as far as the azygos is there. This is related to the pericardium. Then, of course, the number 1 pericardiophrenic. Same, the blue ones there would indicate the veins. Although it's not shown here, the red one is not going up to the brachiocephalic. Okay, some of them will go directly to the intermediate. Nerve innervation still receives a branch coming from the phrenic nerve. Simply to C5, it is primarily somatic, meaning motor in function. Sensory fibers coming from C3 to C5. So it receives 2 innervations. One is somatic, which is from the phrenic. Then you have also from your cervical to C5 basic section. And this is the reason why also when take note, remember the dermal layer C3, C5. C3 is somewhere at the base of the neck, going back to the shoulder. So if you have diaphragmatic irritation, sometimes maka-feel ka shoulder pain. Okay? Irritation lang. Meaning there is a you may have problems with lungs, for example. Some of the patients will complain of nerve numbness on the shoulder, primarily because of this guy. Okay. Of course, it has to occur at the ipsilateral, meaning on the same side of the lesion. So, sabot na ko, if the diaphragmatic irritation is coming from the left, it should not go to the right. It should follow the ipsilateral or same side. Okay. And of course, it receives also parasympathetic innervation coming from, can you still remember what is the vagus nerve? Cranial nerve what? Premed. Huh? What is cranial nerve ng vagus? Cranial nerve 10. Very good. This guy, you will see or hear this guy all the way up to the aluminal tract. Kadumugtag vagus from the thoracic heart, it also is that long, it provides also innervation to the small intestine. So it just goes to show the cranial nerve number 10 is so long. Okay? Taas kayo. Coming from the brain, the dula long data, it's a cranial nerve. Then goes down all the way to the aluminal tract. That's how long the cranial vagus nerve is. And of course, the sympathetic tract is pretty vascular. So, what nerve innervation na? Sa pericardium. Okay, so following the course, both between the parasympathetics and the sympathetic. Okay? Going towards the pericardium. Now take note, guys, that this particular innervation has nothing to do with the heart's purpose. Do not confuse the phrenic, do not confuse the C3 to C5 with the function of the heart. Okay? As far as nerve innervation, this is just for the pericardium. everybody knows that the control of the heart is inherent, right? Pacemakers, the SA know, that will be further discussed next week. But you can control heart rate externally through the vagus. If you want to have increase in heart rate, that has nothing to do with the SNO. So it can be influenced externally still. So if you want to stimulate the vagus nerve to increase or decrease heart rate or raising the cervicals, you can still control them. So meaning the function of the heart, as far as nerve conduction I mentioned, is the regular heartbeat lang. But if you want to control it, if you want to increase it, and that's the reason why we have athletes, makakontrol ba sila silang heart rate, right? But based on external na, this still plays a role. These two guys still plays a role in the function, nothing to do with training. Okay? These two guys plays a role pa rin for the control of the heart rate and contraction. Okay, some of the clinical conditions that you might see in pericardium, this is the one I mentioned. Normal pericardial, that is what we go with pericardial effusion. Okay, laki din ang difference, no? So you can see the difference now when the heart, the pump, restricted siya because of the space. Okay, unlike the lungs. And of course, if you take an X-ray, you can see the difference. Now, you need to have a radiographic eye to tell you that that particular X-ray has nothing to do with the heart enlargement. That is pericardial effusion. There's a big difference. Sometimes, nakuha si mong heart, mag-okay ng heart anak. Okay, that's the heart there is normal. It's the effusion. You need an X-ray like this to give you a guide where you will off your needle and go pericardial pieces. Of course, this is different from trauma, which is tamponade, which is blood here. It only takes about 15 to 20 milliliter or milliliters of fluid or blood to stop the heart. Okay? To stop the heart, you need to stick that. Ayaw naman kayo ng pericardial fluid. It's only about 5 or even less than 10 cc. Times 2, it restricts the contraction. Dito kinakalas. But there are cases where you have acute versus chronic. The chronic ones are usually ma-adjust na heart. But the acute is different. Okay, acute meaning trauma, chronic usually mga inflammatory diseases. Again, as I mentioned, TB. Okay. Sige, so, di na kung break up. I'm going to shift to the another part of the lecture, which is the more interesting. Leo here is actually still fixing my lapel. I will probably finish my lecture on Yapon. Actually, nabuba ang amplifier. Some group destroyed the amplifier daw on Sunday. Is it my students ang naguba sa amplifier? Ako na nakaguba sa amplifier last Sunday. Ha? Dili ka mo.